Skin to skin is the practice of placing a newborn infant naked and prone on the mother's chest. This should ideally be done immediately at birth and throughout the postpartum days. Skin to skin has numerous proven benefits. According to Alan Cherry et al., a study has shown improved breastfeeding duration, cardiorespiratory metabolic stability at birth, and improved temperature regulation. The study also shows that skin-to-skin care at birth reduces stress associated with birth and facilitates self-regulation. Neurobehavioral benefits and positive parenting impacts are evident even after a decade, making skin-to-skin at birth the optimal method of care. Multiple studies have proven the effectiveness of skin-to-skin. A study by Koojman et al. Even showed less postpartum depressive symptoms in mothers who conduct skin-to-skin with their healthy full-term infant. Despite all of this research, skin-to-skin is underutilized with healthy full-term infants. Multiple studies, including those by Alan Cherry et al., Farello and Hatfield, Koopman et al., and Zwedberg et al., state that despite the known benefits, skin-to-skin has not been fully accepted as practice for full-term infants, whereas it is more fully accepted for preterm infants. So essentially, skin-to-skin is the cheapest and arguably simplest possible treatment and prevention tool available, yet it is not always being utilized. The purpose of this presentation is to identify barriers to the use of skin-to-skin and outline ways to overcome these barriers. This leads us to the research question. The research question is, what are the nursing barriers to the implementation of skin-to-skin and what interventions may be effective at overcoming these barriers? To break that down into PICO format, the population being researched is nursing staff. The intervention is identifying nursing barriers to skin-to-skin. In this PICO question, there is no comparison intervention. The outcome is to overcome the barriers to skin-to-skin. The next step in the research process was finding articles. The articles used in this presentation were found through PA College Open Athens account. The primary databases used include Sinal Complete, Metaline, Ovid, and the EBSCO databases. The search term started broad with just skin-to-skin, which brought up many research articles that did not relate to infant mother skin-to-skin. After adding infant, it narrowed down the search, but still had too many results. To further narrow, the terms healthy and full term were added. This narrowed down, but didn't quite include barriers. It mostly included studies on the benefits of skin-to-skin. So the search terms barriers and nursing were added. Other terms that were used include kangaroo care. All of the research reviewed for this presentation are primary resources. The articles had to be peer-reviewed and published in the last 5 years. To narrow this down, we included this in the search criteria. The specific articles were chosen for their focus on the healthcare team's perspectives. The article also had to address barriers to skin-to-skin, not just the benefits. As you can see in the article titles listed on the slide, common themes emerge. This was how articles were initially selected and then further analyzed using the abstract. The first article was chosen because it outlines both the mother and nurse's perceived barriers and compared the two. The second article was chosen because the study highlights the benefits of skin-to-skin and sets a background and demonstrates the importance of the practice. Article number 3 was chosen because it includes the perspective of a variety of clinicians, and it compares the barriers of vaginal delivery and C-sections. Article 4 was included because it also included the input of various members of the healthcare team, and it highlighted suggestions to overcome the identified barriers. Article 5 focuses on the midwives' perspectives, Across the articles, cesarean delivery was identified as a barrier to skin. This article looked specifically at the barriers caused by C-sections. The research process was challenging. It took patience to find articles that specifically addressed the research question. There is an abundance of studies on the benefits of skin-to-skin, but there are far fewer studies on the barriers. Many articles also focused on preterm infants, so finding studies about full-term infants was a challenge. Many themes emerged throughout the studies. One important difference to note is that each article includes different members of the healthcare team. The results are not exclusively based on nursing input. However, nurses or nurse midwives are represented in each study. Koopman et al., Alan Cherry et al., and Swedberg et al. Cited lack of skin-to-skin education among staff and parents as a primary barrier. Other barriers identified include time, mother's condition, cultural differences, and logistical barriers, such as IV lines and monitors, which are more apparent in C-section deliveries. One contradiction throughout the studies is that awareness and education were identified as both a barrier and an enabler. Alan Cherry et al. Said, awareness and belief in the practices of skin-to-skin at birth came up as both a barrier and an enabler. Within all the limitations and restrictions of the system, the overwhelming belief in the practice is one of the key enablers of the practice. So this was a point of contradiction amongst the articles. Farello and Hatfield did not identify education as a barrier. Rather, they stated that the benefits of skin-to-skin are known to both nurses and mothers. This disparity is likely due to cultural differences. All the studies took place in different regions of the world. It was difficult to find research only pertaining to practice in the USA. The study by Farello took place in the US, where skin-to-skin has taken deeper roots than other areas of the world. The study by Farello and Hatfield identified barriers that were not mentioned in the other studies, including privacy violation from constant interruptions by staff and visitors, and also safety. One nurse included in Farello and Hatfield's study said this in regards to skin-to-skin. The patient's room are like revolving doors with hearing screen and environmental coming in and dietary. There's so much to do. When can you fit it in? It would have to involve a complete change in the way we do care. This was an important inclusion in the focus group section of the study. Koopman et al., Alan Cherry et al., and Swedberg et al. Made recommendations for staff and parent education as ways to overcome the barriers to skin-to-skin. All of these articles also mention having a designated nurse to ensure skin-to-skin. Koopman et al. Went on to describe implementing a transition nurse in C-section births. The nurse would have specific tasks outlined, one of which includes skin-to-skin. Multiple articles cited the lack of staff as a barrier to skin-to-skin. So this recommendation addresses that. Koopman et al., Swedberg et al., and Alan Cherry et al. Also mentioned the use of partner skin-to-skin. If a mother is too tired or unable to, the partner can facilitate skin-to-skin with almost all of the same benefits. Farello and Hatfield identified more specific practices, including afternoon quiet time, specific garments for skin-to-skin, and modified visiting hours to allow quality time between mom and baby, and time to rest. They also mentioned partners skin-to-skin if mom does not feel safe with the baby. The literature synthesis process was challenging. The process started by reading each article and highlighting key points. Each article was then further analyzed using a worksheet to identify methods, main points, recommendations, and the sample. The worksheet made it easier to identify themes throughout their articles and any glaring differences. The data collected across the studies was relatively similar, which made the synthesis a little easier. This also demonstrated the validity of the data. The challenge was that because info was so similar, it was difficult to keep the studies straight. After analyzing the research, one common recommendation to overcome barriers to skin was implementing patient education. Zwedberg et al., Alan Cherry et al., and Koopman et al. Mention the benefits of antenatal education on the benefits of skin-to-skin. Koopman et al. Said nurses and medical doctors believe that education of clinicians and parents on the benefits of skin-to-skin and establishing a clear protocol can play an important role in promoting skin-to-skin. Zwedberg et al. Also said that a major obstacle is that many parents lack knowledge about the benefits of skin-to-skin. Farello and Hatfield confirmed this by saying that most nurses believe that mothers were unaware of the benefits of skin-to-skin and did not spend enough time in skin-to-skin. All of this supports the need for nurses to implement education on the benefits of skin-to-skin. Nurses are often the primary educators during the postpartum hospital stay. Equipping nurses with the tools to educate on skin-to-skin will promote more frequent utilization. Alan Cherry et al. Says, in reference to skin-to-skin promotion, that these behavioral changes require effective communication aids such as audiovisual aids and antenatal counseling. A video about skin-to-skin could be included in standard admission education. Another beneficial tool would be a poster in each patient room. The poster should outline how to do skin-to-skin and the benefits. This would act as a constant reminder for parents. Implementing this new practice may bring a few challenges. It will require time to make the video and the poster. It will also require the finances necessary to do so. It may also take time for nursing staff to integrate the tools into the admission education. While it's important to consider these barriers, the barriers seem small compared to the benefits of skin-to-skin. To summarize, skin-to-skin is often not prioritized during the postpartum stay, according to Zwedberg et al. The main barriers included patient knowledge, patient motivation, time, and logistics. The main solutions identified throughout the research included antenatal and postpartum parental education about skin-to-skin, implementation of partner skin-to-skin, and designated quiet time. The recommendation that emerged from this evidence-based practice study was that postpartum nurses should include skin-to-skin education in admission education, and that there should be in-room posters outlining the benefits as well as an educational video tool. Implementing these evidence-based practice recommendations will promote the use of skin-to-skin and help to overcome the barriers identified in the research. Thank you for listening.